Today, our patient is a 35-year-old lady who's an engineer by profession who has had no comorbidities except intermittent migraine episodes for which she was on SOS analgesics. She was apparently well till 1 month ago when she developed history of sudden onset weakness involving left upper and lower limbs with no associated headache, blurring of vision, slurring of speech or seizures. She was managed with dual antiplatelets with complete recovery within 2 days with no residual neurological deficits. Her vitals were stable, her saturation was normal, no, she had a normal CVS examination, and on CNS examination, she didn't have any residual neurological deficits. This is her chest X-ray and ECG. The X-ray shows a normal heart shadow with no abnormalities. The ECG shows sinus rhythm with normal QRS axis and normal LV forces. We evaluated in detail her in detail. Her baseline investigations were all normal. Her thrombophilia workup, including protein C, protein S, antithrombin 3, lupus anticoagulant, ANA, and homocysteine, were all negative. She had a normal CT carotid and cerebral angiogram, and transthoracic echo showed no structural heart disease with normal chamber dimensions and good ventricular contractility. Her MRI brain showed an acute infarct in the right capsuloganglionic and corona radiator regions with normal cerebral angiogram. The ROPE score, which is the risk of paradoxical embolism score, her score was 8, which showed an 84% probability that the cause of her stroke was probably can be a PFO. We'll go on to the transesophageal echocardiography. Here you can see that there is a small PFO which is shunting left to right in the first image. There is a still image which shows the shunt across the PFO. We then did a bubble contrast echocardiography to her, where on Valsalva maneuver you can see that a few bubbles escape into the left atrium.
This is initially we screened to look for any evidence of other causes. This is the aortic valve. We can see that the aortic valve is tri-leaflet with without any thickening or any abnormality. If you see it in a explain, this is the long axis of the aortic valve, which shows the cusps are normal with normal mobility without any thickening, and this is the mitral valve, where we can see that in a 0 degree the mitral valve leaflets appear normal, and this is the color which shows there is no significant mitral regurgitation. This is in the long axis view, where we can see that the mitral valve is normal with very trickle of regurgitation which is not significant. This is the left atrial appendage. You can see here, this is the mouth of the left atrial appendage, and in this we can see that there is no thrombosis, and on pulse wave Doppler we can see that there is there is clear the contraction of the left atrial appendage that is documented. So then coming back to the septum, this is the septum in the 0 degree view. This is the atrial septum, this is the aorta, and this is the left atrium, and this is the right atrium. Here actually we can see a small flap of tissue.
Okay, Pramod, yeah, that's good. So basically, you have excluded mitral valve abnormalities such as, say, a thickened fleshy mitral valve prolapse, an aortic valve abnormalities such as calcification or a vegetation or something on the mitral valve that could be aortic valve that could be responsible. You also demonstrated that there is a normal atrial contractile velocity that says that the left atrial appendage is normally contractile. There was no historic evidence of any atrial arrhythmia. There is no thrombus in the left atrial appendage primarily. So we are now showing that there are no features of cardioembolic stroke apart from the PFO that you are currently demonstrating. You are able to see the septum secundum and the septum primum, and between the two there is a minuscule flow. Primarily now it is from the left atrium into the right atrium. So since we have demonstrated right to left shunt of the agitated saline contrast in the outpatient clinic a few days ago. So while we are waiting for the multipurpose catheter, can I do some agitated saline injection? So what I do for an agitated Pramod, I'm going live. Okay, what I do for so this is the agitated saline that is being injected. You can appreciate clearly that there is a. Can you increase the proximal gains? Yeah. So during each inspiration, you see that there is a shower of contrast. Pramod, like it's quite spectacular, Pramod. You are showing beautiful images, and I am finding that with each of her inspiration, there is so much of shower. You see that? See the amount of contrast that is entering the left atrium. Normally they say you have to calculate the number of bubbles, and here there are hundreds. See the amount that is crossing over from the. So I think it is quite convincing that we are dealing with a situation which needs a closure. So can you get me the wire inside at present? So currently we are entering into the pulmonary artery, and we are going to be documenting the pulmonary artery pressure. We are now having pulmonary artery pressure. There is a lot of respiratory fluctuations that are seen because of the patient being on a conscious sedation. However, we are finding that the pulmonary artery mean pressure is around 20 millimeters of mercury, which is normal. So now we are coming into the right ventricle. The right ventricle pressure too is normal. Now coming to the right atrium. Again, it's showing a lot of respiratory variation due to the deeper levels of sedation. And so now I have crossed through the patent foramen ovale. Now put a 3D there and show me. It just walks through the foramen ovale. I'd like to get a stiff wire, an Amplatz super stiff guide wire. Followed by that, I would like to get the Amplatz PFO delivery system. So currently we are getting in with an this is a super stiff guide wire. Now you have actually lifted the septum primum and the septum secundum by the wire. Can you measure the distance between the two septum? It seems to be just about 3 to 4 millimeters, right?
It's like 3 millimeters.
3 millimeters. Okay.
3.5
Now,
millimeters.
also, can you find out what is the distance from the aortic root, and you can also explain how do you choose the device based on the distance from the aortic root?
On the right side of the screen, whatever we are seeing is the short axis image, where this is the point of crossing and this is the aortic valve. This is almost 180 degree because this is a 90 degree and this is the explane of it, which is 180. So this is the aortic valve and this is the region of the retroaortic. This is the retroaortic region. From here to here, if I measure now, it comes to
Fluorostor?
quite lot of, it comes to almost 15 millimeter here, but I'll recheck again.
Can you show that on a 0 degree plane itself so that our measurements are even more clearer?
So we can, we don't see any tunnel here.
Yeah.
I measured that time, it was just 3 millimeter here.
Yeah.
And this is the, this is just
Wire tip.
This is
Yeah.
the wire tip, and there is no, and this is the septum. This is the tip of septum secundum, and this is the tip of septum primum. So we don't find any difference, any large.
What is the length between the aortic root and the?
Now I have measured the length from this PFO to the aortic root.
It's around 10?
Around 10 millimeters.
Okay. So we will keep that in mind. Now let us concentrate on the way in which we are de-airing. So currently what we have is the Amplatz torque view delivery system. The long delivery system is kept here, and we are holding it with underwater, and because the patient is on spontaneous respirations, there is going to be a lot of negative intrathoracic pressure, and so there may be a possibility of an air embolism. So currently what we are doing is slowly removing it and allowing, in fact I'm keeping the guide wire also inside. The reason is to prevent the guide wire, prevent the sheath from getting wedged within the pulmonary veins. And so there should be a free backflow of the blood. Now we are seeing the blood gushing through. It's a good gush through of the blood. So now, having satisfied with the amount of blood flow, now I am withdrawing the guide wire. Sister, coil the wire, please. I'm keeping the sheath. Now I'm putting my thumb and I'm controlling it. Okay, that's good. So now we have got the sheath across. So this is a 10 French sheath across. And you were mentioning that the distance between the foramen ovale and the aortic root is about 10 millimeter. So if let's assume I am choosing the smallest PFO device which has got 18 millimeter on the left atrial side and 25 millimeter on the right atrial side, I probably should not be encroaching onto the aortic valve. Don't you think, Pramod?
Yes, sir.
Okay, so let us open an 18 by 25 PFO device, 18 by 25 PFO device. It's by the Abbott Medical. So once we open, we will show the device. We are getting a beautiful view of the sheath going from the inferior vena cava, going all the way into the patent foramen ovale. So let me connect it to the three-way. So this is the three-way system. I will DR the three-way system. You can put in the light here. So this is the Amplat's torque view delivery system, and this has got an 18 millimeter disc on the left atrial side and a 25 millimeter disc on the right atrial side. The right atrial side is intentionally kept larger because our primary intention is to prevent a right left embolism. So at this point, you are going to load the device. So this is the PFO device. I'll just show. I'm recapturing the right atrial disc. You can appreciate clearly that it is a non-self-centering device, which means the waist is very small, and the entire right atrial disc has been now captured. Now what we have is only the left atrial disc, and the left atrial disc is also captured now. So I will open it again. So at this point, what we'll request is, sister, can you flush out? Keep on flushing. Keep on flushing. That's wonderful. Thank you. Close it. Can you flush once again another 10 ml of saline? Close it. Perfect. So now what we are going to do will be, so we have locked the Amplatzer delivery system, and show me live TE. So right now we are advancing the 1825 PFO device through the 10 French. Yeah, it has reached the left atrium. I'm able to see that the device is actually past the sheath. You can see that the sheath lumen has become opaque now. I'm going to open the left atrial disc in the left atrium and going to draw it back. So it's nicely getting approximated against the atrial septum. So this is the right atrial disc. Can you capture the fluoro and then show us? Show the image. So this is the left atrial disc that has been deployed. And the right atrial disc is getting deployed. Okay, so that looks fine. So can we check it on a 90-degree view?
And now we can see that this is the 90-degree view. This is the superior vena cava, and this is the inferior vena cava, and this is the device. The LA disc is clearly seen, that is smaller disc, which is seen on the left atrial side, and this is the RA disc, which is seen clearly within the RA. Because of some tension on the cable, it looks angulated, but once we release, it should be becoming flatter.
Okay. Yeah, so right now I am injecting agitated saline with blood into the right atrium. So I'm having a good filling of the right atrium. So that's a good filling. Can you show me a replay of
I'll just
that?
play it again.
Yeah.
This is the recording that we have done.
Yeah,
You can see
sure.
that the right atrium is completely filled with the bubble contrast, but we can see that there is not even one bubble of contrast that is crossing into the left atrium. So it is
Fine.
good. There is no flow of contrast. There is no right to left shunt as of now.
Yeah, that's excellent. Pramod, that's very reassuring. So right now, I will do one thing. I will release the device so that, we should be able to check it. We can see that the screw is getting slowly unscrewed.
Yeah, now it is.
So there is a complete release now.
Now in the
The,
TE we can see that the discs are both the LA and the RA discs are well aligned, and we can see that there is no this is the left atrial disc which is smaller and the right atrial disc which is larger, and both are well aligned with the atrial septum. Good that this patient didn't had a very large aneurysmal floppy septum that could be there in some patients, but this was a good case where we can see that there's a well alignment of both the discs, and color also shows there is no flow of any there's no shunt across there's no residual shunt anywhere.
Pramod, now that I have completely released the device, can I do once again another agitated saline injection?
So ready
I
for
am now giving.
firing.
So there is a reasonably good swelling, a good contrast opacification on the right atrium. Can you take one image on a 0-degree plane so that we see in the other axis? Yeah, that's good. That's good. So I'm actually filling the right atrium completely, but we are not able to see anything going across into the left atrium. Now I'm giving a good injection. You are not able to see the contrast in the right atrium because of the shadowing created by the large device. But one thing is clear, that there is no bubble that is entering into the left atrium.
So do you routinely use figure of eight sutures to secure the site for large sheets?
Well, we can give a manual compression also. We can. It's just a 10 French sheath. We can give a manual compression. We can put a figure of eight stitch, and about maybe 3 to 4 hours later we can remove it. You are showing good images. This is it the left atrial view, Pramod?
It is from the left atrial. This is a 3D acquisition from the left atrial side. We can see this is actually from the left atrium. This is the septum, and this is the left atrial disc. We can see here, and if I turn it to the right atrial view, here we can see that this upper one is the superior vena cava, and this is the larger right atrial side of the disc.
Thank you very much. So that was Pramod, you have actually demonstrated that there is no right left shunt in the across the foramen ovale, and the device is in a stable position. Now we have to take out this 10 French sheath, and as Tejasvi was pointing out, one of the option will be to give just a normal manual compression. Another option will be to take a figure of eight, so that we are currently taking a brief figure of eight, which will keep for about 3 to 4 hours, and at the end of 3 to 4 hours withdraw it. But once her effect of dexmedetomidine goes off, we will probably take it out. So the figure of eight is taken with one bite just above the sheath and one bite just below the sheath, and we'll tighten it out. Thank you very much, Pramod, for an excellent imaging, and thank you, Tejasvi, for moderating the session, and thanks, Dr. Anand, for assisting me. Thanks, Dr. Uday, for keeping the patient comfortable on dexmedetomidine. Prabhu and Ravi, the cath lab managers, for giving us all the support with all the gadgets. The Abbott Medical, which provided the PFO device. It's an excellent device, and we will probably meet on another day with another interesting intervention on the same session. Thank you very much. Goodbye to all of you.